Okay, this is from your book. This, I believe, is chapter 10. It's pretty good, doesn't it?
Is the screen? Yeah, it does look good. Yeah.
Okay. Yeah, this is chapter 10. Oh, yeah, leave this one on. Okay, this is chapter 10 of the textbook on focal and diffuse choroidal and retinal inflammation. And I am going to talk on white dot syndromes. I have trouble not going deeper into the topics. So I'm going to talk just on the non-infectious ones, and then I can add the infection one later. So the first part I'm going to talk about is the AZOR complex diseases. This includes people who there tend to be a female preponderance. There's visual field loss, photopsias, and there's usually outer retinal damage with these diseases. So these are sort of, there's lumpers and splitters, and these have kind of been lumped together. Some people say they should be split. So it's multiple evanescent white dot syndrome, acute macular neuroretinopathy, paracentral acute middle maculopathy, which is not in your book, but I think will probably be in the next edition, and then multifocal choroiditis, panuveitis, PIC, punctate choroidopathy, and AZOR. And then at the end, I'll talk about a couple more white spots. So before we get going on it, I get frustrated. There's advantages and disadvantages to grouping things. And I think the advantages, people remember them. I think it's a memory thing, like, oh, white spot syndrome. I can tell you the disadvantages, if you either don't understand them or you're lazy or uninformed or whatever, it leads to misdiagnoses. And so you'll see, to my mind, these are all completely different. I don't have any trouble distinguishing these. I have a very close friend who's a medical doctor whose son came through the program, his sister she said she's got a problem. She saw a retina guy. It's either mute. They're not sure it's a white dot thing. It's either mutes or birdshot. And I said they're different. That's like saying, he's either got a broken arm or a broken leg. It's not interchangeable. So I think people get into this trap where they look at the white spots and say, oh, here's the differential, da 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 da. Now some of them are similar, but a lot of them are different, and hopefully that'll come across. So to start, mutes is one of the most common ones. Mutes is unilateral. Most of these are bilateral, so mutes is unilateral, which is good to know. Usually healthy female, age 15 to 50. They tend to be younger, women 4 times more than men. Again, that's going to be true of all the first ones I'm talking about. A lot of these have a viral prodrome, and then there may be an association with vaccines. We have a couple cases we've seen. In fact, you guys might be writing one up on a vaccine. It's acute, painless, unilateral vision loss, and they get the photopsias, dyschromatopsias, and paracentral scotomas. There's a specific type of photopsia in all these. So what you'd ask, of scotoma. So what you do is you ask the people, they'll say they have a blind spot. My daughter's best friend was over our house one Saturday, and she was saying that she was seeing spots in her vision sometime. I thought she might have MS. And I said, well, all the time? She goes, no, sometimes. I had her cover one eye, and she could see well, cover the other eye, she couldn't. And she had vision loss in the one eye, and it turned out to be mutes. And what mutes will describe is a dark spot, but it shimmers. So it's different. So if you have somebody with a dark spot in their vision, that can be a retinal attachment, a bunch of things, a vascular occlusion. But if they have a dark spot that shimmers, that means there's something going on with the outer retina. So it's called a shimmering scotoma, which I have to say, the OCT has made all this a lot easier. Back before the OCT, a lot of these were very difficult to diagnose. So to start with the case, this is a 17-year-old girl who has had vision loss for 2 weeks in her left eye, no viral prodrome, but she got a flu shot. The vision, the right eye's 20/20, left eye's 21/60. This is actually the recurrent case that one of you has to maybe write up. And this is her left eye. And what you'll see in the center is the macula, the center of the fovea is a little bit mottled. It's got this funny-looking granular appearance. On the photo, it's always easy to see the white spots, and they're sort of on the left of the picture. If you look over here, those are typical mutes white spots. They're sort of small. These tend to be actually, most of my mutes patients are teenagers, and it's a lot easier to see them on the photo. The other characteristics of mutes, the autofluorescence is striking. So the autofluorescence will show the spots. They're these little hyperfluorescent spots because of the outer retinal damage. And then the fluorescein is probably just the autofluorescence. So when you look at the fluorescein, you see the same white spots as on the autofluorescence. I don't think the fluorescein adds that much. The ICG, though, shows a lot more dark spots. So this is an ICG. typical for mutes. The OCT will show outer retinal damage. So if you look at this OCT through the center of her macula, you notice that especially the interdigitation line's missing, and then most of the detail in the center of the macula is missing. I point, but it's hard to do this angle. So with mutes, the testing, you've got an FAF, and an FA is helpful. The OCT is helpful. The ICG is very helpful, and you can get visual fields. Mutes is associated with acute idiopathic blind spot enlargement syndrome, which I don't even see that much separate. People have that one's sort of not talked about that much, because I think it's kind of been rolled into mutes. Historically, there was a time when the two of them were different. A lot of these are described in the last 30 years. As far as the pathogenesis, treatment, and prognosis, mutes is probably viral or post-viral autoimmune, and the prognosis is excellent. Excuse me, so one of the things in mutes is the E is evanescent, which means it goes away. So if you're going to make the diagnosis of mutes, you just wait a little while. If the vision loss, if the problem doesn't go away, it's not mutes. So that's mutes. And this is one of the most common ones. I'll show you later. There was it's hard to, these are all relatively uncommon, but there was a paper recently that gives you a little bit of an idea of the relative incidence of all of them. Acute macular neuroretinopathy. Somebody brought a case in, I think, 4 meetings ago. But the OCT is very helpful. This used to be impossible to diagnose. You get a brown wedge-spaced lesion centrally that people describe a blind spot, very similar. It's usually teardrop configuration, a little bit of vision loss, and they'll still get the photopsias, tend to be young white females in the same complex, but the SD-OCT shows exactly where the lesion is. This was, I think, from a review. Survey of Ophthalmology had a good review on this recently, talking about the symptoms, the scotoma. It's most of the patients, 73%. It can be associated with a febrile illness, about 50%. And then there is this sort of weird, there used to be this epinephrine association where people thought it was post-anesthesia. You can see it in other circulatory disorders. This was a lady I saw, I think 5 years ago, a 40-year-old. She had no prodrome, and then her vision was 20/50. She said initially her vision was good. She saw a spot in the vision, and then it moved closer to her central vision. She did have lupus, though. And this is the color, which usually shows almost nothing. But if you look hard, just to the left of the fovea is the little bit of abnormality. Does anybody remember from the case about a year, 6 months ago, what's the test that shows the best on this? It's kind of weird. It's a test that's not usually that helpful. Yeah, the infrared. Did you have the case? Yeah, the near infrared is great. So this is the infrared picture, and it shows the dark spot just nasal to the fovea, which is exactly what the patient will describe. And then the autofluorescence is normal. And this one caused me to do some research. The autofluorescence comes for the blocking the macular pigment is in the axons of the foveal cones. So unless those are affected, your macular pigment's normal. So the macular pigment looks normal in this disease, which sort of surprised me, but now that I learned more, it doesn't. The fluoresceine's pretty normal, the ICG's pretty normal, and then the OCT shows the spot. So, and this is this weird outer retinal abnormality. It's not in the capillary. I'll show you what PAM is the next case. So when you look at the inner and outer capillary plexus, you can see where PAM happens. This may be from the outer capillary plexus or something deeper in the outer retina.
This pattern is Mude's pattern?
This is acute macular neuroretinopathy. This is
pattern.
AMN. So this is a typical AMN OCT. You know, if you see this, I can't imagine they would do this to you, but if you saw this on the boards, this would be AMN. It's only one thing. Testing the IR reflectance is the best thing. Visual field can show the scotoma, but probably only a 10-2. The other tests are normal. That would be a great board question. If I was writing the boards and really wanted that a fluorescein and ICG are normal, because you wouldn't expect that. When I studied for the boards, I went through all the books, and every time I hit something that didn't make any sense to me, I wrote it down. And that's what they usually ask you on the boards. So anything that, because I remember somewhere, the solar retinopathy has a normal fluorescein angiogram is in your book somewhere. And I thought, gosh, I wouldn't expect that. So I put it, and I think every time I took a practice test, that question was on the boards. So anything, so that I think that, oh gosh, normal fluorescein, you would expect that. So I think I was writing the board question, I put that on.
I presented a case of this apparently in 2015.
Oh, that was yours, okay.
Yeah, and you can see really good on the color, that little wedge shape.
Yeah, that was your case. I remember.
Yeah.
That was a good case. And that was where that's when it forced me to look up the macular pigment. And then the ERG, and it's all would be normal. Multifocal, I guess, would be abnormal. The prognosis is pretty good. This is probably viral. Again, it's like the other AZOR disease, no treatments known. The prognosis, my patient did fine, but if you look at the literature, it's about, I think, 50, 60% of people get better. Some people have a persistent spot. I have to say, the older literature is going to be muddied on this because it was a very hard diagnosis to make. So I think in the next 10 years we'll get better data, because with OCT and all that and IR, it's much easier to tell when people actually have it. Paracentral acute middle maculopathy is kind of fun. This is an OCT diagnosis. It's again a parafoveal gray lesion. It's a little more superficial, sudden onset scotoma. You can see it on the OCT, and some people are, there's an issue now whether it's part of acute macular neuroretinopathy or part of just retinal vascular disease or who knows what, but it has to do with the capillary plexuses. This is a lady, if you look, there was a paper that came out a couple years ago that many central retinal vein occlusions have PAM lesions. And I have a case in my deck, I'll show it when I have time in conference, of some good PAM lesions. This was a 56-year-old with a central vein occlusion. Sudden vision loss. The FAF showed good circulation. Her vision went from 2160 up to 2060. This was her color photo, which looks pretty good. She's got the hemorrhage in all 4 quadrants. The veins are a little dilated, but not bad. But if you look around the center of the macula, there are those little gray spots, little subtle. They're kind of subtle. They're not cotton wool spots. And then you look at the OCT, and do you see the whitening in the middle retina? I guess I can use this, right? Is that working?
Mm-hmm.
Okay. So like right here and right here is the whitening, and that's paracentral acute middle maculopathy. And that's when this is the one disease, or one of maybe 5 diseases, who knows, where the OCT angiography is going to be really cool. Because what you're going to see is the superficial capillary plexus is going to look normal, but the deep capillary plexus is going to have gaps or voids where these infarcts are. And this has to do with the macular anatomy, the vascular anatomy. Again, we'll see it on OCT, which I don't have yet. There's the superficial intervascular plexus, which is at the ganglion cell layer, and the deep outer vascular plexus, which is at the internuclear layer. And the PAM lesions are probably occlusions of the outer vascular plexus, which doesn't show on FA. So your typical FA shows mostly the intervascular plexus, not the outer vascular plexus. You treat whatever they have. Somebody wrote up a case that we had a Birdshot with a PAM lesion. He did neuro-ophthalmology fellowship down at Bascom.
Drew Carey.
Drew, okay. Drew wrote up a case we had. It took forever to get it published. But it was a PAM lesion in Birdshot, and again, you see with central vein occlusions. I have a case with just a little PAM lesion that came in with a small vascular occlusion. And so you just sort of treat whatever's wrong with them. And the prognosis for this is good. Multifocal choroiditis, panuveitis is another white spot syndrome. And this again happens in females. It looks a lot like histoplasmosis, but there's bilateral involvement and there's some uveitis. So if you have someone who's got all the risk factors for histoplasmosis and no uveitis, then they have histoplasmosis. Otherwise, it's multifocal choroiditis panuveitis. And when you see this in the active phase, it's very hard to diagnose. And I think I have a photo. Yeah, I don't have an active photo. So this is a 35-year-old woman who had vision loss 15 years ago in one eye, and then the other eye 4 years ago. Her left eye had been treated for all sorts of things, and now she's noticing vision loss in the left eye again. The vision loss in the right eye is 20/50, left eye is 20/80, and this is the left eye. This is a neovascular membrane. It's not really active uveitis, so they're very high risk for neovascular membranes. These are the multifocal scars, though, in the right eye, which are kind of typical for multifocal choroiditis panuveitis. They're a little bit bigger than you see in PIC, and the OCT shows scarring, and then this is the left eye with the active lesion. And now, sometimes it's hard to tell whether that's here's an FA, whether it doesn't really show vascular, and I don't think the ICG showed a vascular plexus. So it's possible that was an inflammatory lesion, but we usually treat them as neovascular. I don't believe the OCT showed any active uveitis. Yes, I think this was probably just a vascular lesion. these are some of the multifocal choroiditis, panuveitis in the active phase is very hard to diagnose. You see, because sometimes it'll be one spot. So they can have one spot of active inflammation, which looks exactly like toxoplasmosis, or smaller. They tend to be paracentral, and they're very scary. Actually, I do have a woman who was an emergency room doctor who I think had this diagnosis with a single spot. She had chickens. In St. Pete, you can raise chickens. So, but her test came back negative for histoplasmosis. So that made me think it probably was this. This is not that common. The vision usually improves, so it's a lot of multifocal choroiditis. So they can have vision loss, they can have the scotomas, floaters. Anterior uveitis is not uncommon. The vitritis is required, otherwise it's histoplasmosis. The lesions are scattered, and they will look just like histoplasmosis. I took a picture out, but they get these linear peripheral lesions, just like histoplasmosis patients get, and then chronically they look like multifocal scars. And acute and chronic lesions can be seen together. Peripapillary scarring is similar. It looks exactly like histoplasmosis. And they can get CME, and they can get neovascular membranes, 25 to 39%. I have to say, one time Dr. Gass was talking to me about something when I was doing my fellowship, and he used to call it pseudo-POHS, which I had never heard of. And it's disorienting when your mentor's talking to you about something which is obvious to him that you should know about, and you've never heard of, and you're trying to get through the conversation so you can look it up when you're done and not look like an idiot. But so it's also used to be called pseudo-POHS. You can do testing, fluorescein and ICG, and, visual field. These also can get a blind spot enlargement, which is one of the reasons all this stuff gets clumped together. Possible viral etiology, steroids can be used, and that's one of the difficult things. Before we had the anti-VEGFs, you used to inject steroids, and they did respond. So some of this is probably inflammatory. And there's a subretinal fibrosis variant, which is really nasty. I've had 2 patients in my career. One's a young African-American lady, another one's an older Caucasian lady who disappeared a couple of years ago. She doesn't come in that often. They get aggressive subretinal fibrosis, multifocal choroiditis, and they just lose vision. And it's very hard to control. And they probably, I'm not very much into systemic drugs, but those patients probably should be on serious systemic drugs long term. The lady in Sarasota used to come up was on long-term steroids. Punctate chorioretinopathy, I think, is one of the more common ones. So of what I've shown so far, what I see more than a couple times in my career are MUDES patients I see periodically, and PIC patients I see periodically. And this is something that people used to say didn't exist. They just said it was a form of multifocal choroiditis. I gotta see what we're up to for time. Good. But basically it's myopic females, young, like everything else, bilateral 80% of the time, small lesions, that's what that would call it, punctate. And they're at the level of the choroid and the RPE. And subretinal avascular membranes are super common in these patients. This is a lady I'm still managing with aggressive PIC. She's a 34-year-old. I think someone was going to write her up because we've been using Lucentis on her through serial pregnancies, which everybody says is crazy, but it's probably not unreasonable. She's had hazy vision. She saw waviness in her vision. She does have a history of Sjogren's syndrome, and she's got fairly severe Sjogren's to the point where she's been on systemic medicines for it. She's a moderate myope, which is common with all of these. And so she's been on Plaquenil, and she's been on and off Remicade and other stuff. The vision at this point is 20/25, right eye 20/20. Ultimately, she lost the vision in the right eye, and the left eye is hanging on by a shoestring. So this is the right eye, and this is what active multifocal choroiditis would look like, or active PIC. And it's these white lesions, but they look, and there's probably a blood vessel where that hemorrhage is, but the other ones do look milkier. They don't look as, and you see how small they are. I can use this pointer. Here we go. So this, like there, these are just tiny. You don't really see, there might be one bigger, but these are all small lesions. Here we go. And this is the left eye, which similarly has a couple small lesions. That one's a little bit on the big side, but so that's why we call this PIC. The autofluorescence doesn't show much, just where the scarring is, and then probably an area that's had fluid for a while. The left eye autofluorescence doesn't show much. The fluorescein will show dark spots where the PIC lesions are that stain later. So they do fill, and that's what multifocal choroiditis would look like if you had a picture of it. And then the ICG stays dark. So, but then this is helpful, because when you have all these dark lesions on the ICG, that's a neovascular membrane. So I like ICG I use this for macular degeneration patients too. If you're not sure if there's a neovascular membrane, a late ICG will show it to you. Here's our OCT, which shows a bunch of fluid by the neovascular membrane, and the left eye shows all these little bumps by the PIC lesions. So it's possibly, same as everything else, possible viral steroids and immunomodulation can help. The CNVs can be treated, intravitreal Kenalog can help. In the absence of neovascular membranes, they do fine, but in the presence of neovascular membranes, they can have trouble. It can recur. She's had recurrent PIC, and but there are patients who just have one episode, and the vision's usually 20/40 or better. So that's PIC. Any questions? I'm just kind of rolling through this because it's a lot. And then AZOR is acute zonal occult outer retinopathy, which was just, this was during my fellowship, this got published, so that was 94. And it's where people will get blind spots. And again, these, when they come on acutely, these are those shimmery scotomas. So it's the same thing. It's a blind spot that shimmers. They tend to be young, myopic women. And the reason it was acute is because you really didn't see anything in the fundus initially. So it's usually initially unilateral, ends up being bilateral later, and they can develop recurrences, and there is sometimes a mild vitritis, but not always. There was I guess I'll get to that later. So the one thing I'll tell you about AZOR when you see people, because it's rare to see an active one, but it's not uncommon to see somebody who had it a while ago, is that it looks like asymmetric RP. So if you see someone where they have, and this was a guy that came in to see me, I don't know, a while ago, I think 10 or 15 years ago. In the one eye, the right eye was normal, except for a nevus, totally normal. The left eye it looked like RP. So there was bone spicules, outer retinal atrophy, the vessels are narrow. If I did in other testing, you would see that there's RPE loss, and that's typical for AZOR. This is retinitis pigmentosa, which is just symmetric. So in a dystrophy, it's exactly, you can almost flip one eye into the other and it's symmetric, but in the AZOR patients, they're not. So the ERG will be dysfunctional, visual field will show defects. The OCT shows outer retinal atrophy in the acute phase. So in the FAF is often abnormal, even in the acute phase. So it's really not that occult anymore. With the testing that's been developed in the last 5 or 10 years, you should be, but the thing is, with AZOR, it's rarely central. It tends to be peripheral. So you're gonna have to do a visual field, find a visual field loss, and then bring them back to your OCT and put a scanner over where the field loss is. And when you do that, you should see outer retinal atrophy. So it shouldn't be hard to diagnose. Oh, this was an interesting patient. Paper came out this year, 2017, where they did anti-retinal antibody tests on, I think it was 12 patients with AZOR, which is a lot of patients with AZOR, and they got 100% positivity. So it's probably autoimmune. Now here's about the anti-retinal antibodies. Anti-retinal antibodies are positive in 30% of the population. So the fact that you've never ordered them is good. Do you guys ever get them? Good, okay, good. That's a good sign. Because there are a number of practices that order them. I never order them. It would, for a study though, for an AZOR study, I think that's a great study. But I think in clinical practice, I don't like them. And I've had 2 patients in the last 3 years, I want to say, who were sent to me with autoimmune uveitis on systemic medicines for it. One of whom had chronic central serous retinopathy and didn't need the medicines. The other one who had nothing and have floaters or something. And so it was weird and had to stop. They were getting all nervous. The second patient I just saw in the last 6 months, there was this big thing about what to do because she was having liver toxicity from one of the drugs and she didn't tolerate another drug and she had this autoimmune retinopathy and she had nothing in her eyes. The visual field was normal, the OCT was normal, so we just stopped everything. So anyway, but AZOR probably is an autoimmune retinopathy. So to go back, AZOR complex diseases are multiple evanescent white dot syndrome, acute macular neuroretinopathy, maybe paracentral acute maculopathy, multifocal choroiditis, panuveitis, PIC, and AZOR. And these all have the females, visual field loss, photopsias with those shimmery scotomas and outer retinal damage.
One question. How do you tell the difference between PIC and multifocal? Yes.
They're smaller, the PICs are smaller.
Just smaller?
Yeah, smaller. And also tends to be, I guess they're both young females. Also, PIC is just way more common. I can say for multifocal choroiditis, I haven't seen it that much. I'm going to talk about two, we're going to go three more that are important. So the two are block early, stain late diseases. Those are rare. There's acute posterior multifocal placoid pigmenopathy. I have a pretty busy practice, and I've had 2 patients in my career with this, and serpiginous choroiditis, and I've had 1 patient with active serpiginous. So these are rare, but there are characteristics of them, and they're typical, so you need to know. So AMPI is acute onset, tends to be bilateral, blurred vision, sometimes photopsias. The antecedent flu-like illness is not uncommon, and men and women are equally affected. That's why I think it's not with the AZOR ones. This was a 25-year-old guy that came in a while ago. I got a lot of nice pictures of him. He had night chills, and then his joints started hurting. He got headaches. They weren't too severe, and then subsequently he got vision loss. And he's got blurred spot, which aren't his central vision, and the vision is 20/32 in both eyes. And this was a picture of the right eye. These are the typical AMPI lesions. So you get these white spots that are much bigger, they're milky, they're placoid, no hemorrhage with it. And then this is the left eye, which similarly has these white spots that are placoid. Does anybody off the top? We've shown a couple cases for infectious diseases. What you worry about with the placoid lesion?
Syphilis.
Yeah, syphilis. So syphilis can look exactly like this and tuberculosis. But you showed the one you guys had, the one from the VA. That was probably a tuberculosis lesion. But this was, I have to say, I didn't test this guy, I don't think, for syphilis. The syphilis ones tend to be solitary, and he was so typical for AMPI. The autofluorescence shows these, this is later, so this is not in the acute phase, shows these little areas that are slightly abnormal. AMPI patients maintain pretty good vision, even if it's under the central vision. This was an FA during the acute phase. It does the block early, stain late. So so this is early here, and they block, and this is late, and they stain. And a lot's been made of that, how that can happen. Anyway, you can read about that. And then the ICG blocks early and blocks late. So it looks different and on the ICG, you sometimes see more lesions. They're very subtle, like this spot here, which is super subtle on the FA, and maybe not even present on the color, shows up as a well-circumscribed dark spot. And then the nice thing now is the OCT shows the lesions very nicely. And so on the OCT, you get these outer retinal. You can see where people lose their vision. The RPE is pretty intact. The choriocapillaris looks a little funny. And then you get this disorganization of the outer retina. The inner retina is totally fine. And that's the right eye of this patient. Excuse me. So in AMPI, you get a vitritis. It's a uveitis. So you get a mild uveitis behind vitritis. They get the multifocal lesions, outer retina and choriocapillaris. You can get the muscles. You can get anterior, episcleritis with that AMPI, in case I think that's in your book. But, and the other thing that happens, there's a case report from before I started practice, probably 25 or 30 years ago, of a patient dying from cerebral vasculitis with AMPI that was a local case. I want to say it was Dr. Grisard's case, or maybe Dr. Hammer's. And so when I was working with them, and I had a patient with AMPI that was doing, I thought, okay, and they saw the patient and threw him in the hospital and put him on IV steroids because they had that patient. And so there is this thing where you have to worry. So this person had a mild headache, but AMPI can actually be lethal. So if someone comes in and it's like, oh, my head's really killing me, then you probably should throw them in the hospital and put them on IV steroids because of the cerebritis. The differentials, like we said, syphilis and TB and sarcoid can look like this. The FA blocks early, stains late. The ICG blocks early and blocks late. The OCT shows the lesion. Sometimes there is subretinal fluid, and the FAF can show bright or dark. There's the case you guys showed a couple weeks ago, the last visit of this Serpiginous showed that typical bright hyper FAF. And AMPI, and there was a case somebody brought in, I want to say 6 months ago, of an AMPI, and that showed the FAF was very bright too. So I think in the acute phase it looks brighter. It's possibly a delayed hypersensitivity. There are HLA associations with AMPI. As rare as it is, it's interesting, so it's been studied. And you can do steroids for cerebral findings. The prognosis is good vision, but not normal vision. So that's one of the ways you differentiate ampi from serpiginous, is the ampi patients look horrible, but their vision comes back. So they'll be 20/40, 20/30. Serpiginous doesn't. So serpiginous is the same as ampi. So the lesions are usually except for the lesions are usually peripapillary. They grow. Serpiginous is typically recurrent. Ampi usually isn't. The vision does not return over the scars. Recurrence is common. And again, this can be tuberculosis like the case you guys showed. And for serpiginous, you do aggressive immunosuppression. This was the case, excuse me, I had of active serpiginous. I still see her. She's weird. She's a snowbird, but like a 1 month a year snowbird. It's been really hard to manage her because she comes and goes and nobody else does what I want them to do. So the picture on the right is her eye that was involved years ago. And this shows all this stuff, all these scars everywhere. This eye is actually 20/50. She has a little window in here that she sees with. And then this case was, she came into me in 2011 where her right eye, which had been totally clean, was seeing some floaters. And she started to get these milky white lesions off the nerve in the right eye, and that's active serpiginous, which is kind of scary because it's nowhere near the central retina in her better eye. I guess that's the only picture I put in. Oh well. I do have some other pictures of her. I couldn't find them all, where you can see the little active lesions at the edge. She would grow like active lesions there and there and there when she was active in her bad eye. So she would periodically activate. Again, they block early, stain late. Oh, that's the whole thing. Okay, so on serpiginous, so there's a little more on serpiginous. I don't have it in a lecture. I got lost as I was doing this, and I think there's a couple different files out there. But it is appropriate for serpiginous to put them on very strong drugs. And I want to say she was on azathioprine and something else for a year. There's some thought you can put serpiginous into remission by the uveitis specialist if you give them a year of really strong drugs. Not methotrexate, like Remicade, the real killer anti-metabolites and stuff. So serpiginous sometimes gets treated. I was trying to get her on serial intravitreal steroids in the right eye. My idea was to use AZOR every 2 months on the right eye for like 2 or 3 years to just shut it down. But she ended up going all over the place, and she is quiet now. The right eye is worse. She's gotten a bunch more lesions, but it hasn't gotten inside the arcades. So these are block early, stain late, and they're rare. Birdshot is very common. This was that thing I was telling you about. This was a paper that came out 2 months ago in OSLI Retina, where they looked at, they were looking at testing. So it was the value of testing in white spot syndromes, which was pretty much just not very valuable. I thought it was a weird paper, but anyway, one thing that was interesting was they had a lot of patients, and they had a relative frequency of patients from a couple institutions, and they had half their patients were birdshot. So birdshot's one of the more common ones. They had a lot of ampi and serpiginous, and so some of it I think is what you're looking for. Birdshot patients have decreased vision, floaters, night vision loss, dyschromatopsia, glare, photopsias. It's kind of vague uveitic symptoms, and this is the official characteristics. I'll put this up on the website so you can look it over later. I think I'll put the slide decks up on the website too. I put the video, but I'll put the other stuff too. So they have to have disease in both eyes. They have to have greater than 3 peripapillary birdshot lesions in order to be diagnosed, and they have to have uveitis, but they can't have too much uveitis. So it's sort of like, if they have a hypopion, it's not birdshot, it's Michette's or something else. So they can have inflammation, but not too much, and that tends to be helpful for diagnosing birdshot. And then an HLA-A29 is helpful. Retinal vasculitis and CME, and like I said, keratic precipitates, posterior synechiae are not something you see in birdshot. And this is an official birdshot diagnosis. Birdshot's the strongest association of any HLA type in any disease that I know of. So 80 to 98% of patients are HLA-A29 positive versus 7% of the general population. When you write for an HLA-A29 lab test, I don't know, you might be able to on them on the computer. I know I always get an HLA-B27 back. So what I write now is I'll write HLA-A29 and then I'll write not HLA-B27. That's like a whole sentence, so that they hopefully won't give me an HLA-B27. So you want an HLA-A29, which is helpful. And when patients will ask you, why are you getting the test, or what is my HLA type? What I say to them, which I think is correct, you guys are newer in school, so you might know better. What I tell them is every cell in your body tags itself so it knows it's you, and that's your HLA type. So it can tell yourself versus something else. So it's not something you would treat. It's not like you're going to change your HLA type, but it's helpful diagnostically, and it saves you from a lot of trouble. Fundus photos are helpful. The lesions can be subtle. Autofluorescence doesn't show much. Fluorescent angiograph doesn't show much, but ICG shows you spots really well. This is a nice ICG test. The ERG and EOG are abnormal. I don't have that, but you guys do. And then the visual field can show loss, and the OCT is not that helpful. There's some controversy, I think, about how aggressive you should be with Birdshot, and there's a study going on, and I emailed the authors a year or two ago, and they didn't have much more information. But there was a weird paper published, I want to say 4 or 5 years ago in AJO, on a cohort of Birdshot, about 70 or 80 Birdshot patients that they were going to study. It was a funny paper saying, we're going to study these patients, and it gave all the characteristics. But then it didn't, there's no follow-up from that yet. I've kind of been waiting that, because what a lot of people would say is Birdshot patients need to be treated aggressively because they get so much loss of visual function. They'll say that they lose peripheral vision, they lose night vision if you don't treat them. My experience with Birdshot patients is not that. I have a lot of Birdshot patients that are fine. I probably have 10, and I want to say I don't do anything for probably half of them. They're fine. They're kind of quiet. They have Birdshot lesions, and they seem okay to me. So we'll see. So this is a typical Birdshot. So you see the, oops, hold on. These are different patients. Center of the macula looks fine. They can get CME. That actually does look a little CME-ish. But these are the typical Birdshot spots. These little creamy white things. They're not elevated. They're not really active. You can often see vessels through them. They're like little atrophic areas off to the side around the optic nerve. I do have a patient with macular Birdshot. So there are some people who are a little bit atypical, and the A29 can be helpful. This was a lady, I did not expect this. This was a lady who came in with a moderate uveitis, and I was doing a bunch of sort of a workup on her looking for things, and she had no spots. That's why I couldn't bring in her pictures, because she had no spots visible, but when you did the ultra wide field ICG, she had like all these spots all over the place, and her A29 was positive. So she's a Birdshot patient, and she ended up traveling to a uveitis center where they implanted Retisert implants in both of her eyes, and she actually got central serous retinopathy from that, and glaucoma, and cataracts, and then she has a membrane, and but anyway, she's doing fine. She's in the medical profession. So these are hypopigmented choroidal lesions, 200 to 500 microns are kind of big. They're clustered around the optic nerve and radiating outward. They usually spare the macula. It's usually females, a little bit older, 40 to 60, and they can get macular edema. The main thing I look for is macular edema, and I treat the macular edema. Subretinal neovascular membrane neovascularization happens, but rarely. This is maybe 1% or 0.5%, whereas PIC and multifocal choroiditis are almost 50%. Birdshot's rare. And I think, and then pathogenesis and treatment. It's clearly autoimmune because it's got the HLA association. Steroids in the short term, immunotherapy in the long term. This was that paper that is why people treat. Without treatment, this was a paper that came out, I guess, in 2005, which is some time ago. They had, without treatment, 16 to 20% of patients were 2200 or worse in 10 years. And with treatment, they had patients doing better. So that's the paper people look at when they say you should treat everybody. What I do is I treat them if their CME is bad or if their vitritis is getting bad, just based on their symptoms. I don't treat them if they're asymptomatic. And that's the whole thing. So that's all non-infectious. That's the best I could do. That chapter's got a lot in it. So I'll try to do the infectious ones later. There's a whole maybe February we'll do that, and I'll email you guys with whatever topic we're going to do in February, and then I got to hand you off to thank you for giving us the time for the pediatric lectures. Any more questions about white spots on that?
For these eye-only ones, how do you decide between systemic immunosuppression versus the Retiserts and the Luby and AZOR?
Local. I'm very much a local person. I just do local. I don't. The systemic stuff. I guess that's not necessarily true. Because they are young people. So if you're trying to do cataract sparing therapy, then systemic is probably not that bad an idea if you can get something that's got acceptable side effect. Like methotrexate, like it's not so much for these though. Not so much for the white spots, but for the uveitis. Methotrexate's pretty mild. So I'll use methotrexate on that. And if I had a Birdshot patient, I mean, that's not such a bad thing to use on people. There's not, it doesn't, for this lecture, systemic versus local isn't such a big deal because they don't so much need it. But even for the systemic uveitis, like I've had patients with sarcoid, if they don't have lung symptoms, you can treat their eye. And I tend to do posterior subtene on Kenalog a lot. I don't put stuff in the eye that much. I've never put a Retisert in. When the price tag was just $18,000, an implant was just kind of high. The Ozurdex we use some, but Ozurdex has a pretty short it really is. It was sold, I think they were trying to get it as a 6-month or a 3-month drug. It really lasts about 2 months. Ozurdex, if you really want to get activity out of it. There's a lady that's been lecturing on slurry, she's got a trademark on it. Kenalog. You can spin down Kenalog. Have you guys done that at the university? It's pretty, nowadays we have, I think our office has centrifuges for some of our studies. And if you put Kenalog in a centrifuge and spin it down and inject it, you actually can get intravitreal activity, I believe, longer than Ozurdex. And I think you can get about 6 months. And it goes through a 30-gauge needle. I've not done it yet.
Steve, how do you come up with 20 over 32?
Oh, the ETDRS charts are that way. This 2032, 2063 or something. The ETDRS, there's no 2030 on them. They're 2032. Yeah, that's what we use now. All right, well, we'll take a little break and then we'll hand you over to our able pediatric colleagues. Thanks for letting us use the time.